Hi, my name is Evelyn. This is my difficult airway video. The first thing that I'm going to do is I'm going to come in the room and assess my machine. So I just want to make sure it's plugged into power and I have an extra ambu bag for emergencies. And then the first thing I'll check on the machine is the gas pressures for my tank and my pipe. So my pipe should be 50, around 50, and then my tank should be 745, above 745 for nitrous, and then above 1,000 for my oxygen. And if it's lower than that, I'm going to replace it. And then I'm going to check my volatile gases. I'll make sure those are filled up and the caps are on tight. Make sure my interlock system works. Once I've gone through that, then I can do my low pressure system check. That should pass, and then I can turn on my machine. Once my machine is on, I can check my link 25 and my flow meters, make sure there's no leaks there. I can check my O2 analyzer, my CO2 absorber, and then my scavenger system. And I also want to make sure that my monitors are all turning on correctly. I have all my equipment and gear for the machine to operate correctly. And then once I've done that, I can do a high pressure system check. In reality, right now there's no oxygen in this room, so I can't perform it physically, but what I would do is I would close my APL valve, O2 flush until the pressure gauge reads 30 centimeters of water, and I would have that hold for 10 seconds. Once it holds, I know it can deliver high pressure to my patient, and it passes. So once I check that, I can check my manual and my ventilation modes on my machine and make sure those check out and work. And then once I've done that, I have passed off my machine. So once my machine's ready, there's a couple other things I'm gonna grab just to make sure my room is checked off. So I just wanna make sure I have some common IV drugs for the case that we're doing. And what we are doing today is an elective laparoscopic cholecystectomy, and we're doing this on a 55-year-old male, and they're 100 kilograms. Their ASA is 3 and they're a BMI of 35. So just based off that information, I can start kind of thinking that this might be a difficult airway. They're an obese person that is going to require some extra help. So my IV drugs that I'll need for the case though are midazolam. So pre-op, I'll probably give 2 to 3 milligrams. My fentanyl is 50 to 100 mics per kilogram. So this patient I'll give 100 mics, and then lidocaine 1 to 1.5 milligrams per kilogram. And I'll just need that to blunt the sympathetic surge of intubation. And so I'll give her 135 milligrams, and then propofol 1 to 2 milligrams per kilogram. I'll give 200 milligrams. Rocuronium, I'll give 0.6 to 1.2 milligrams per kilogram, and then I'll give 100 milligrams of that. My SIVO for maintenance, I'll probably use between 2 to 3%, but I might high pressurize in the beginning depending on my propofol, how long it takes to intubate, all of that. So Zofran between 4 to 8 milligrams, and I'll use probably 8 because this is a bigger individual. And then my emergency drugs that I might actually want drawn up, I'll have atropine, 0.4 to 0.6 milligrams, and I'll have 0.5 milligrams drawn up. And then my succinylcholine, I'll have 1 to 1.5 milligrams per kilogram. I'll have 100 drawn up. And then my epinephrine, 1 mic per kilogram, my phenylephrine, 0.5 to 2 mics per kilogram, and then my ephedrine is another emergency one. That's 5 to 10 milligrams for a max of 25 milligrams. And you just give 5 to 10 milligram boluses depending on their blood pressure. And then some other things besides meds is I'm gonna have my blades. So I'll have a MAC 2 to 3, and then I'll have a Miller, actually I have a MAC 3 to 4 and a Miller 2 to 3. And then because I'm anticipating a difficult airway, I'll need to also grab my glide scope. I'll grab a McGrath, so that's handy. I'll have a fast track, an LMA readily available. And then I also want to have my emergency airway cart, my difficult airway cart. I want to have some oral airways, some nasal trumpets. I'll also have a crite kit, some bougies, pretty much everything that I would ever need to use in an emergency. And once I have all those kind of collected, I'll have lastly my ATTs, and I'll probably have an 8.0 for this guy, but that's just a guess. I'll have half size up and half size down, and then I'll have my stylettes, I'll have some lube, I'll have some egg crate foams, I'll have an OJ tube. This patient, since they're obese, they might have some GERD or some regurg during the case, and I don't want that to affect the case or the recovery. I'll also anticipate securing the tube 22 to 24 centimeters, but that'll change depending on anatomy. And then before I go pre-op, I'll probably go just heads up another CRNA or anesthesia provider for help and let them know that I might need help during this intubation. So once I have all those things collected, I can go back to pre-op and I can pre-op my patient. So I'll just go back, introduce myself, talk to them, ask about their medical history, ask about their medications they're taking, see if they have MH history, see if they have any allergies, if they're NPO for the adequate amount of time. I'll discover they have hypertension and they have diabetes type 2 and they have obstructive sleep apnea. So once I've kind of talked about their past history, I'll just go over some labs and make sure those have been done prior to the case. And then I'll go into a physical assessment. So I'll listen to heart and lungs. I'll ask if they smoke, if they utilize a CPAP at night or whenever, what their settings are, if they know. This patient, I will be able to see that they have a goatee and a mustache, and I'll see if they would consider shaving or not for the surgery. And then other things that I'll assess upon walking in is I can do a very thorough airway assessment. So I would want to ask them to open their mouth as wide as they can. I would want to assess their Malin-Potty. This patient will have a Malin-Potty score of 3. I won't be able to see very far into their throat, and their incisor gap will be above 3 centimeters. So they can open their mouth, they don't have any buck teeth. I'll ask them to stick their tongue out, see if that will help their Malin-Potty at all. Another thing is I'll ask them to move their neck around to see if they have good neck mobility. If they can bite their upper lip with their lower teeth. I'll also see their neck thickness, and if I need to, I can measure, but this patient is obese, so it's obviously a bigger neck. And their neck, the length is average, but the thickness is not. So that would also clue me into this might be a harder, just with extra tissue intubation. I'll ask them to jaw thrust, see if they have any TMJ. If they have a receding chin, I'll see if they have any loose teeth. If they've had anesthesia in the past, what did the provider do to intubate them, and if they even know that. One other thing is I can do a 3-3-2 for the mouth opening, the hyoid-mental, and the thyroid-mental. I'll ask if they snore, I'll ask if they have voice hoarseness, I'll go over all of that with them. So once I've kind of done a very thorough airway assessment and formulated what my pre-plan for intubation is going to be to myself, I can go over the consent with this patient, make sure they understand the risks, they understand the procedure of anesthesia, and I can give them a deslam and I can move them back. So once they're back in the OR, I'll just ask them to scoot over to the bed, and I'll put my pulse ox, my blood pressure, my EKG stickers on, and a warm blanket. And then because I anticipated a difficult airway, I'll also have some blankets for ramping to try and align their airways. So they'll all be ramped up so that I can have an easier time, hopefully, intubating this patient. So once I have all of that set up, I'm just gonna explain to them that I'm pre-oxygenating them. They just need to take some deep breaths, and I'll hold the mask over their nose and mouth and cheeks, and I'll try to listen in case there's leaks just based on this. Because I have a beard, I'm probably gonna have to use Tegderm or something and gel to try and create a good seal. When they're more asleep, I would maybe, after induction, I would maybe have to lift their cheeks into the mask, or use the double hand technique, 2 CEs, and use a second provider to help induction and intubation. But once I have kind of assessed that and done that, and we've been pre-oxygenating at 100% oxygen for 3 to 5 minutes, then I can attempt my IV induction. So we're pre-oxygenating right now. I'm just gonna use my fentanyl, my lidocaine and propofol, and push those. And then I'm gonna go through 3 scenarios. So now they are asleep, they're in stage 3. They have no lid reflex, they are just completely relaxed. The first scenario is that I can mask ventilate for this case, but if I couldn't, I would have to call for help and utilize that CRNA or the anesthesia provider I talked to earlier. And I would try to optimize positioning and kind of troubleshoot and see why they weren't able to ventilate. I wasn't able to mask ventilate. So do I have a leak? Are my airways aligned? Do I need a jaw thrust? Do I need to use my adjuncts like a nasal airway or an oral airway? I'd probably consider an LMA or a fast track, and I would prepare an invasive airway if it's emergent and they're destatting, they're not tolerating apnea very well. And then I would consider waking the patient up and just redoing an awake intubation for this procedure. So that's the first scenario. The second scenario is I can ventilate them, but I'm having trouble intubating them. So if I'm having just trouble with a normal blade and ET tube, then I would try a glide scope first, or a McGrath is a good option too. And if those aren't working, but I can still fall back on masking the patient, then I would try an LMA fast track. and see if that was able to secure an airway, or if I was able to move air with the fast track and then transition to intubating them. If I was having just a hard time like going through all of those options, I know I can mask them, so I can fall back on that and take breaks to do that. But I don't want to do more than 3 passes. I would probably also consult my CRNA buddy that came in, and I would say, like, what do you think is happening? How come we can't intubate? We troubleshoot that way. And then the third scenario is that you cannot ventilate and you cannot intubate. So this is when you would probably want way more hands on deck. You would call for help. You would talk to the other providers, your anesthesia providers. We would try the fiber optic scope. We try the glide scope. Try the LMA and consider an emergency airway. Probably a retrograde intubation would be next in the flow chart, and then cric would maybe be next unless the patient was able to wake up. I would only do a cric if they were destatting and it was just really a true emergency and they just needed an airway. So pretty much, third scenario, if you can't ventilate, you can't intubate, you have to wake the patient up and do an awake intubation. So now I'm ready to intubate. I've masked them. They're intubated, or they're not intubated, they're asleep. So I will first use my glide scope to intubate and visualize this airway. So I'll take my glide scope, I'll take my lubed tube with a stylet in it, and I'll just attempt intubation. So you'll put your glide scope in and then lift up their head. They'll be ramped, so all their airways will be hopefully aligned. I'll visualize cords on this camera, and I'll make sure not to rock back on the teeth while I'm using this. But once I can do that, then I can place my tube in. Let's see. It's really easy with the camera. I'll ask my assistant to pull the stylet out so that I don't damage the vocal cords. I'll advance a little bit further, and then I can take the tube out all the way, take my glide scope out, I can inflate my cuff, and then that is my airway I just got pretty easily. So advantages of using the glide scope is it helps visualize an anterior airway. The curvature of the camera and the blade helps with that. It also clears the tongue. It's fashioned after a Mac more than a Miller. It reduces the need for excessive force, and there's higher success in obesity versus other blades. So another option that I could try if that didn't work would be to use a fiber optic scope, and that is this. And so with this, since the patient is asleep, you could attempt using this without having any assistance, anyone to like clear the tissue out of the way or move the tongue. Since the patient's asleep, they can't do that themselves. Fiber optics are useful for awake intubations because the patient just has their own airway protected and they can open their own airway. But anyway, so I'll use my assistant and I'll have them use a blade, probably a Mac, to help clear that tissue and that tongue out so that I can have an easier time maneuvering this. But it's not necessary if you can just maneuver this without this help. So I'll thread the tube over this fiber optic, and then I'll have my assistant intubate and help me clear that tissue and visualize the glottis as best as possible. And then I'll try and keep this straight and advance this little tube into the mouth. And then that's on now. So now I can see where my tube is going, and I can adjust it so that it goes into the correct space through the cords. And then once I see that it's through the cords, then I can advance it a little further, pull my fiber optic tube out, and then inflate my cuff and secure my circuit to the patient, and then tape the tube to the patient. But those are just two options. Benefits of this fiber optic is that you have a camera and a light at the distal end, and it has a lot more precision navigating the airway. You can get around the tongue or redundant tissue. You can also see exactly where you're going through the cords. It's kind of like a controlled bougie. It's more trustworthy seal than an LMA, so if you're having trouble placing the LMA, this might be a good option. You can also suction and give oxygen through this and other things that are kind of helpful for intubation. But so once my tube is secured and my cuff is inflated, then I can tape this patient's eyes. I can give my paralytic if need be, and then turn my SIVO on around 2 to 3% just for maintenance, or maybe higher. I could high pressurize them just because it took a long time to intubate. I'll reduce my oxygen to 2 liters a minute, and then now I can just reassess for loss of consciousness, and I can scan my monitors, make sure their eyes are protected, make sure their pressure points are well protected, and then we can proceed with the case. And that's just the end of the video.